The supraspinatus is the most common rotator cuff injury. It's actually one of 4 rotator cuff muscles inside of your shoulder. If you think of each one of these 4 muscles as a motor that powers the shoulder, the injury to the supraspinatus only affects one, and that's why you could still have reasonable function because the other 3 motors are still working. So the larger the tear, the larger the deficit of strength. Now, the thing that's unique about rotator cuff is that these tendons are actually spring-loaded like rubber bands. So if you have a partial tear, it's still connected, but it's under a lot of strain, that can create quite a bit of pain. Once you get to a full tear and this snaps like a rubber band, it begins to separate. And as this separation gets larger, that's when we start seeing more weakness, more symptoms, and more pain. Because this has separated, it's impossible for any type of rehabilitation to reattach rotator cuff. So when we do see full tear and we see that there is pain and it's not responding to therapy, then the next step is to consider the surgical option. Rotator cuff surgery today is done arthroscopically. And what the intent is to take the rotator cuff which has separated and reattach it to where it tore from. Now, most rotator cuffs, when they tear, they actually pull right off of the bone. So we need to reattach that tendon back to the bone. Bone is too hard to actually sew into. So we actually use plastic pins, or anchors they're called, and these go into the bone, typically 4 or 5 millimeters in size, and coming out of these pins are sutures. These sutures we literally will sew through the tendon itself and then tie it like a shoelace to reattach the tendon. Once that's reattached, then we'll also make sure that there's no bursitis or bone spurs or calcium that can affect the healing. And all of this is done through very small, tiny incisions because the scope that we use is no bigger than a pencil. This is typically done as an outpatient surgery, and the patient will go home the same day, rest at home for 5 days, and then on day 5 return to the office and actually start exercise. The future of rotator cuff surgery is to improve the healing rates, because one of the issues that we have in rotator cuff is that even though we can connect that tendon back to the bone, it's a challenge to get it to heal. There is a risk of tearing it again, and how can we reduce that risk? So we are working on biologics to try to improve that healing response and reduce the risk of this pulling apart again. One of the newest innovations is now called dermal allograft. Dermal allograft is actually a graft that we can put on top of that tendon to almost double the thickness of the tendon. So when we put the stitches into the tendon itself, that's very thin, it gives us a stronger hold. Liken it to putting a stitch into tissue paper versus a stitch into leather. Obviously, we like leather better to stitch into because it's stronger, and that will reduce the risk of tear. So when we have very thin tissue or we're going back in for a revision situation, this is one of the newest innovations on the horizon that we've been working on, and we're seeing very promising results with it.